Good morning to all of you. At the outset, let me thank the organizers, all the directors, IPCI for having given this opportunity. It's in fact a social gathering also for most of us. Well, nodular calcium, as Dr. Ashok has correctly put across, it's in fact more difficult than having a long run in the morning. Well, this was a Japanese article that was published in 2019 in JACC. You could see that these are the three types of calcification that you could come across in patients who undergo imaging in calcified coronaries when they present with an acute coronary syndrome. Number one, you could see that you have an eruptive nodule over there. Secondly, you could see a superficial calcific sheet. And thirdly, you have nodular protrusion. Well, the first one, eruptive nodules, it's more common to produce acute coronary syndrome. The superficial calcific sheets also can produce more of ACS, and nodular protrusions, it's less common to produce. However, it's more difficult to manage these sort of patients. Well, I start with the case history of a 60-year-old gentleman who presented with class 2 effort angina treadmill, was positive, taken up for angiographic evaluation. You could see that at the left main bifurcation, there appears to be a shelf-like lesion over there. In the cranial view, you could identify that better. It's a tight stenosis over there, and you could also see that there's significant amount of calcification there. So we decided to go ahead with image-guided angioplasty for the same. In the first image, you could see that there is significant calcification at the bifurcation, which is extending both into the circumflex as well as into the left anterior descending artery. And in the second image, we started off with a 7 French EBU catheter through the femoral approach, and you could see that there is significant shelf-like calcification at the bifurcation of the left main. We started off with the imaging. We took an OCT catheter down the LAD and had a run. That's the first image. You could see at 3 o'clock as well as 6 o'clock position, you could see the calcific protrusion into the coronaries, which can be better appreciated in these frozen images. In the top image, you could see that there is a nodule at 3 o'clock position, and the lower image, you could see that there is a nodule which is protruding at 6 o'clock position. But that could be better made out in the 3D bifurcation image. You could see here that it's a slit-like opening of the circumflex artery, and on either sides of the circumflex artery, you could see that there is significant nodules on either sides of the circumflex ostium. Well, we started with rotablation. It was a 1.5 millimeter burr. We wired the LAD, went ahead with rotablation of LAD. Rotablation of the circumflex was quite difficult. It was difficult for us to get into the circumflex with the 1.5 millimeter burr at 180,000 RPM. We went up to 200,000 RPM, and finally we were able to get across. In the first image, you could see that the guide catheter is positioned from above, and then we readjusted the guide catheter from below so that we could have a better favorable wire bias, so that we'll have a better cut at the ostium of the circumflex artery. Now, once we did that, that was a flow in the circumflex artery. We again took an imaging catheter and had a repeat run. Now, this is the first run. This is the first run bifurcation mode. You could see here that on either sides of the circumflex ostium, there is calcific protrusion on top as well as bottom. You could also see clearly that the wire bias is towards the nodule that is on the bottom aspect of the circumflex ostium, which means that with the rotablation, you would do something good for that particular nodule at least. So that second image shows us that the nodule that was low down over there at the floor of the LAD, which had a better favorable wire bias, you could see that there is a shaving up of calcification at that particular area. If you compare the first and second image, you can clearly see that in the second image, the circumflex ostium looks much better following rotablation with a 1.5 millimeter burr into the circumflex. The ostium of the circumflex looks much bigger compared to the first image. Well, now we went ahead with cutting balloon angioplasty. That was a cutting balloon at the circumflex as well as LAD ostium, and then we went ahead with stenting. That's a DK crush technique, meticulously through all the steps. Those were the steps. Part was done, and finally we were able to achieve reasonable flow. Angiographically, you could see that the flow is good. The left main bifurcation confluence everywhere, it looks good. The flow in LAD circumflex is good. You could also see that in the lower frames, that is in the lumen profile, you could see that the stent is very well expanded, good expansion. However, if you look at the 3D bifurcation mode, you could see that the circumflex ostium looks good. The nodule that was present low down there, it is almost not there. It's totally deformed and it's not seen at all. However, you could see that there is a small nodule which is sitting on the top of that particular area, which was partly flattened, but then it could not be totally deformed with whatever we've done. Well, so if you look at the measurements, you could see that the left main was 16.2 millimeter, The confluence was 14.67 millimeters. However, if you look at the ostium of the LAD, where you have that nodule, it was 8.2. It was significantly less, and you could see the proximal LAD was 9.5. So the proximal LAD was 9.5, however, the ostium was only 8.5 or so. So which means that probably we should have done something more for that particular calcium. That we were a bit unhappy that we didn't go with a 1.75 or a 2 millimeter burr to the circumflex ostium. Probably we could have done something for that particular area also, because that is the only area that looks a little bit under expanded. So what more could we have done for this particular patient? Now, when you have a calcified lesion, when you put in a balloon, when you put in a stent, this is what ultimately happens. You do not do much for that particular lesion, and you ultimately end up having a under expanded stent. So when you have a nodular calcification, what all could you do in addition to whatever we routinely do? Probably try to reduce the volume by doing rotablation. You could try a step burr approach. You start off with a 1.25 or 1.5 millimeter burr, go up to 1.75 or a 2 millimeter burr. So then you could significantly reduce the calcification, and also you could have cracking of the calcification with either a cutting balloon or an IVL. So regarding lesion preparation in calcified lesion, when you do a balloon dilatation, it's just like what you see in this image. You wouldn't do much for that particular calcified nodule. However, you could significantly reduce the volume by using rotablator. When you use an 1.5 or 5 millimeter burr, you do not significantly remove the calcification. However, with intentional rotablation, that is with step burr approach, you could shave off more of calcification, and finally you could crack the calcium before deploying the stents. Calcification cracking, you could do a simple cracking with a cutting balloon, or a multi-cracking could be achieved with the help of intravascular lithotripsy. Something similar to what Dr. Vijay had presented, an elderly gentleman, non-dilatable infeval myocardial infarction, 12 hours following thrombolytic therapy taken up for angioplasty. Could see that there is significant calcification there. 7 French guide catheter through the femoral approach. We started off with 1.5 millimeter rotablation. Initially, it was difficult for us to go through, but then at 200,000 RPM, we were able to get across. The flow was good in the right coronary artery. So now we were able to get an imaging catheter across. But initially, we just tried to get it across, but then none of the imaging catheters would go across that particular lesion. So once we did the rotablation, we were able to get the imaging catheter across, and those are the frozen images. You could see that in the first image there is a superficial thin layer of calcium. In the second image seen here, you could see that there is a thick calcification, it's almost 1 millimeter in size, and in the third image you could see a nodular protrusion into the lumen, and finally you could see the eruptive nodule, which is seen. This commonly produces acute coronary syndrome. So we decided that we've done nothing good for him with 1.5 millimeter burr, so we went ahead with a 2 millimeter burr at 160,000 RPM, and we were able to go across and do proper burring. And now this is what we could achieve at the end of 1.5 millimeter burr. You could see that there is no significant volume reduction in the first frame as well as second frame, and in both the images you could see here that there is significant amount of volume reduction with the help of step burr approach. You could also see that this particular area, the calcium has been shaved off with the help of rotablation, which was upsized. So we deployed a 4 millimeter stent post dilated, and when we evaluated it, you could see in both the images that the stent is not well expanded. You could also see that the stent apposition is also not good. However, when we did the measurements were reasonable. How you could see that at 9 o'clock position there is a nodule there on either side. The stent is not well opposed to the vessel wall. It's not a significant protrusion, but then you could see that it's partly deformed, it's partly flattened, but then it's not totally deformed nodule, even though the lumen area looks good. And at this area you could see that there is a good expansion of the stent, where you have a proper volume reduction with rotablation. And at 6 o'clock, 7 o'clock position, you could see that there are areas wherein you have significant cracking of the lesion with the help of high pressure balloons also. So because we made out that the minimal luminal area was good, however the expansion was not all that great, we went ahead with a 4.5 millimeter post dilatation, and finally we could achieve a reasonable flow inside that particular vessel. Now this is another patient who present with an acute coronary syndrome, elderly gentleman, creatinine on the higher side, had a bifurcation stenosis of the LAD, and there was significant calcification of the bifurcation. More at the diagonal calcification was present, so we decided to do an imaging guided evaluation. Since the creatinine was on the higher side, we decided that we'll go with a saline OCT. You could see that we had a selective flush into the LAD alone with the help of a guide extension catheter into the LAD. We took an image from the LAD back, and we wanted to also have an imaging from the diagonal done, but then you could see in the second image that the OCT catheter wouldn't negotiate into that particular vessel. Now in the lower frame, you could see that in the longitudinal view, there appears to be calcific nodules on either sides of the diagonal ostium, exactly at the bifurcation. So this is the pullback from the LAD. This is right at the ostium of the daughter branch of the LAD. You could see that there is a calcific nodule, which can be better appreciated in the lower frozen image. And this is the diagonal ostium. You could see that there is more of an eccentric calcification, and it's almost 1 millimeter thick at the ostium of the diagonal. So this is how it looked like. We had a bifurcation on either side. There was significant calcification, which was extending more into the diagonal also. So our plan was to go with an 1.5 millimeter burr into the LED, then do a step-up burr approach, 1.5 into the diagonal and 1.75 into the diagonal. So we started with we used an 1.75 millimeter burr for LED, and burring the diagonal was quite more difficult. 1.5 millimeter burr, it got stuck. We had to pull it out, and then finally we were able to get across with the 1.5 millimeter burr, upsized to 1.75 millimeter burr, and subsequently we were able to get a reasonable reduction in the nodule. You could see that compared to pre and post rota, you could see that the nodule has been reduced, and you could also see that in the second diagonal ostium, you could see that there is a significant volume reduction with the help of rotablation. It was almost 1 millimeter thick eccentric calcification, which was reduced to 0.6 millimeter thick calcification, and that's the area where you have that particular shaving off of the calcification in the diagonal. Finally, following stent implantation, you could see here that the diagonal, the bifurcation looks good, and you could also see in the lower frame that there is fracture of that particular eccentric calcification, as well as thinning out of that particular calcification with a reasonable opening up of the vessel. Now, is IVL useful in managing these sort of calcific nodules? We had two papers presented at TCT by Kiko Mehara as well as Dr. Siad Ali, which are based on both these articles, both these papers. Calcific nodules can be significantly reduced, it can be deformed, it can be flattened, and even you could have significant fractures of even nodular calcification with the help of IVL. This was an elderly lady who presented to us post-CABG. All the graphs were occluded. You could see that the mid-LED has a stenosis. We started off with an OCT. You could see that there is eccentric calcification, almost 1 millimeter thick, and the third frame, you could see that there is nodular protrusion into the lumen. However, the guide wire bias was good. We started off with an 1.5 millimeter burr, and following the 1.5 millimeter burr, you could see at 11 o'clock, at 12 o'clock position, you could see that a lot of shaving off that calcific nodule has been achieved. You could see that it's smoothened out, and then we went ahead with IVL. That was a 3x12 IVL. You could see here that even this particular calcific nodule, the eccentric calcium, also has been broken off. You could see the fractures there in the eccentric calcification. You could see that the rota has done something good, and the IVL also has done something good for this particular patient. Went ahead with stent implantation, and finally we were able to achieve good results. And that's my last case, a 50-year-old classmate of mine who did MBBS with me, who presented with worsening angina. He had stenosis of the left system as well as right system. Right system was heavily calcified. You could see that in the PDA, the flow was only TIMI2. He had almost like an acute coronary syndrome. So because he had TIMI2 flow in the RCA, we were a bit hesitant to go ahead with the step-burr approach. We decided that we would start off with imaging. The imaging catheter wouldn't go through into the RCA because of the heavy calcification. We had to do rotablation. We started off with an 1.5 millimeter burr, and that was a rotablation with the 1.5 millimeter burr. Once we did that, we could achieve good flow inside the vessel. Then we were able to get the imaging catheter. Even now, you could see that we could not get the imaging catheter fully inside the vessel in spite of having a guide extension catheter. So we did a partial imaging of that particular lesion. You could see that in all the images, there was significant amount of calcification, concentric calcification, eccentric calcification, nodular calcification. All those things could be significantly made out with the help following 1.5 millimeter burr. And now we went ahead with an IVL. That too was difficult for us to get it across. We got the IVL balloon across the lesion with the help of a guide plus catheter, and finally we were able to break the calcium. You could see that there were areas of breakage of calcification. If you could see in the movie that even the nodular calcium has been fractured with the help of IVL. All these images makes us understand that even the nodular calcification could be significantly fractured with the help of IVL. So that's the final result that we could achieve. The nodular fractures can be seen, and the stent expansion was reasonably good. So coming back to Dr. Vijay's case, if I were given an opportunity opportunity to go ahead with this particular case, I would have started this particular case with a 7 French guide catheter through the femoral approach and Amplatz catheter with a temporary pacemaker support. I would start off with a rotablation 1.5 millimeter burr because I'm almost sure that I wouldn't get the imaging catheter across without doing a rotablation. So I would start with a 1.5 millimeter burr, imaging with OCT, step-up burr approach, then go ahead with dilatation, IVL, Wolverine or angiosculp, further imaging, stenting, and then I would do optimization. Thank you, dear friends. Thank you, all the chairpersons, for the opportunity given.